colleagues.
Our speaker now, Dr. Paula Shohdy.
It's a great pleasure to be a part of this great conference. Our case is titled Practice Brings More Questions and More Answers. Okay. A 58 years old female patient, diabetic on oral hypoglycemic drugs for 5 years, complaining of recurrent exceptional chest pain. She was referred for dopamine stress echocardiography to exclude coronary artery disease. According to our protocol in the echo lab, the patient was appropriately prepared by proper fasting. All medications, including beta blockers, were checked. Baseline ECG and vital signs, and IV line was secured. The baseline ECG was, as shown, it was unremarkable with sinus rest. Her baseline heart rate was 80 beats per minute. Blood pressure was 170/80 millimeter mercury. The resting echocardiography was as shown with the standard views. There was a good systolic function with no regional wall motion abnormalities noted. According to our protocol, the dopamine dose was gradually up titrated till we reached 30 mic per kg with still no regional wall motion abnormalities, and the contractility was increasing uniformly. But the blood pressure was rising gradually. It reached at 30 mic, it reached 170/120 millimeter mercury. And the heart rate at that time was 126 beats per minute, which is lower than the target heart rate. At this point, we instructed our nurse to stop the dopamine infusion, and the test was terminated, and it was interpreted as non-conclusive because the patient had no chest pain, no regional wall motion abnormalities, and we still didn't reach the target heart rate. The case was finished, but we have still a lot of questions from this scenario. The first question was asked by our nurse, what is the level of blood pressure at which I shall stop the dopamine infusion? And we answered here by going back to guidelines, American Society of Echocardiography about the dopamine stress echocardiography, and we revised the causes of test termination. The first cause was severe hypertension with systolic blood pressure 220/110 millimeter mercury, symptomatic hypotension, intolerable symptoms, and significant arrhythmia. The second question was asked by the patient herself, shall I receive antihypertensive treatment? And the answer was no, you are not yet hypertensive. What happened is defined as hypertensive response to dopamine stress echocardiography. The third question came across my mind, does abnormal blood pressure response during dopamine have any medical significance? And when we went back to the literature, we found that hypertensive blood pressure response in dopamine stress echocardiography may occur in 9% of cases of dopamine. Hypertensive blood pressure response may occur in hypertensive patients who have suboptimal blood pressure control, patients with masked hypertension, and normotensive individuals. Some normal individuals with hypertensive response may be at risk for the development of hypertension in the future. The mechanism of exercise-induced hypertension is related to failure of systemic vascular resistance to decrease in the face of increased cardiac output, and this may occur as a result of age-related arterial stiffening and increased peripheral vascular resistance. The hemodynamic changes that occur with dopamine simulating and mimics the changes which occurs with exercise, which are increase in the cardiac output and a decrease in systemic vascular resistance. The expected vasodilatory response which occurs with dopamine may be attenuated in the subgroup of individuals who manifest as a hypertensive response. Last question, does hypertensive response affect stress test interpretation? Simply لو عندنا positive wall motion abnormalities in the presence of elevated blood pressure, then interpret as a positive dopamine stress test. Previous thoughts كانت بتقول ان احنا لو عندنا wall motion abnormalities with elevation of blood pressure ده بيبقى فيه high probability ان ده يكون false positive results نتيجة ان بيحصل acute increase في الافتر لود، وده بيؤدي الى وجود wall motion abnormalities لكن في انذر ستادي، ودي كانت لارج ستادي على حوالي 22,000 عيان، كانت اتعملت في مايو كلينيك، بينت ان في القارنت بين البيشنتس اللي عندهم هايبرتنسيف ريسبونس والبيشنتس ويز نورموتنسيف ريسبونس، لقت ان هم فعلا هم مور لايكلي ان يكون عندهم اسكيميا، وكمان هم الفولس بوزيتيف عدد الفولس بوزيتيف فيهم كان زي الناس اللي عندهم نورموتنسيف ريسبونس، ما كانش في ديفرنس في الفولس بوزيتيف ريزلتس بينهم. It shouldn't be assumed that development of full motion abnormalities in the setting of hypertensive response during stress is simply due to hypertensive blood pressure response itself. Such patients should be evaluated or managed like any patient who has positive stress findings. Our take-home messages: severe hypertension to 120/110 is an indication for dobutamine stress echo termination. Some normal individuals with hypertensive response may be at risk for the development of hypertension in the future. And lastly, in dobutamine stress echocardiography, patients with hypertensive response and positive results shouldn't be labeled as having false positive results without further workup. And thank you.
Thank you very much, Paula. Very nice presentation. Any question from Fadal?
شكرا يا بولا. هو from the start why you start to do dobutamine echo, why you didn't do a normal stress test? The ECG was unremarkable. You use to do that in any patient with diabetes, for example. Why you start to by dobutamine echo?
هو last guidelines للchronic coronary syndrome, exercise ECG is downgraded to class 2B. Accordingly, non-invasive test with imaging like SPECT or dobutamine stress echocardiography or CT coronaries.
But I don't think in all our patients we are used to do directly dobutamine or CT. Usually you start by doing the simple exercise test. We cannot recommend that as a general recommendation for every patient with a normal ECG to do dobutamine echo. This is everyday practice. And again, I think if we have any segmental wall motion abnormalities, is a very strong indication. I don't think that hypertension alone can cause. This is an indication that the patient is having underlying ischemia. Definitely. And any patient with extraordinary rise of the blood pressure during exercise usually is denoting that this is a pre-hypertensive state. We should recommend the patient to follow up his blood pressure very frequently and to start on lifestyle modification. Thank you, Paul.
I may answer to your question, why should we do a dobutamine and not a stress ECG directly? There are certain conditions that the dobutamine stress echo is more beneficial for the viability, for the myocardial ischemia. Sometimes we cannot exercise patients on ergometers or treadmill. They have knee problems or cannot have any handicapping. Dobutamine stress echo is still one of the imaging. يمكن هو he did not explain ان الست مثلا عندها arthritis او ما كانتش بقول المره الجايه بولا.
يا بولا انا عندي سؤال بقى بالعكس، يعني مين اللي انت مش هتدخله از ريلاتيف كونترا انديكيشن بالدوبامين ستريس ايكو عشان شاكك ان البلاد بريشر بتاعه هيزيد؟
لو حد ان كنترولد او حد من البيجيننج، ساعات بيحصل مشكله في الكومبلاينس بتاع البيشنت ان هو بيبقى انستراكتد ان هو يوقف البيتا بلوكرز، فبيكون وقف بقيه الانتي هايبرتنسيف، فده بيبقى ريسك ان هو يكون او هو في هيستوري ان هو ان كنترولد بلاد بريشر.
Thank you.